Hello and welcome to the Business and AI Forum. We have a very rich programming for you today here, showcasing how business and business functions are being impacted by AI technologies. Um, Here we have Michelle Currie. She is the founder and chief value realization engineer of Savant Solutions for Healthcare IT. In this presentation, she's going to give us a bit of her knowledge and a bit of her perspective on what it takes to employ real world projects in enterprise environments, particularly in the healthcare industry. She has over 2 decades of experience, so you know for sure that you're going to walk away with something weighty. Uh, Michelle, it's a pleasure to have you, and yeah, I'm looking forward to learning a bit about healthcare from you.
I'm interested in looking forward to sharing with the community. So thank you for having me. Let's go ahead and jump right into it. So we're going to be talking, as Joaquin mentioned, about the adoption of AI specifically in healthcare. That's me. A little bit about my background. Um, so as Joaquin mentioned, I'm the CEO of a professional services company that does clinical informatics types of consulting in the healthcare industry. And our clients range from providers, payers, self insured employers, vendors, and different government entities. Let's go ahead and start off with just a very quick introduction to what is artificial intelligence. This is probably not new, but I like to start with this to ground everyone. So, artificial intelligence is a branch of computer science focused on the development of systems capabilities to perform tasks that normally we would do with our brain. Machine learning is a branch that allows the computer to learn from training data without explicit programming. An example of this in healthcare is different risk assessment tools and patient monitoring applications and different diagnostic support tools. Deep learning is a branch that uses neural networks similar to our brain to stimulate complex decision making. An example of this in healthcare today is image interpretation in radiology. Natural language processing is a branch that uses named entity recognition, sequence segmentation, and parts of speech to transform unstructured data to structured data. Generative AI is a branch of deep learning that creates new and synthetic content, images, etc., from training data, and ChatGPT is the most famous example of this. And large language models are Gen AI algorithms that are used for general purpose language translation and generation, often using transformation architecture. And medical chatbots is a good example of this. Some of the general possibilities for AI in healthcare that we're all very excited about, starting at the top right. So for diagnosis, we're really excited about being able to find new diagnostic methods and specifically more sophisticated diagnostic methods using biomarkers. We hope that it will also lead to quicker diagnosis and decision support related to diagnoses. In therapy selection and generation, we hope to find new medications and treatments through drug discovery and remote therapy, and also to increase our knowledge about rare diseases. For personalized healthcare, this is kind of really the holy grail that we're anticipating with great expectation, is really to be able to personalize treatment for every patient based on their own genomic makeup, and to be able to really identify at the individual level which medications work better for them based on all of the medications available, and also which treatment options are going to work best for them based on their specific genomic makeup. Moving along, administration and operations, there's a lot of work and jobs that different professionals do in healthcare that we're really hoping to standardize and to really automate some of that, including care pathways. And we really want to be able to better predict our demand and capacity availability. For public health, we recently had a pandemic, and we really wish that we had AI during that to really improve and increase our muscle around digital epidemiology and national screening programs, and to also be able to do research and develop some real-time insights in that would have helped drive regulation and policy during that time and subsequently. Prediction, we're using this a little bit already to determine through pattern recognition and to predict different individuals' risks for certain diseases, and even prediction around when those diseases might increase in severity for the individual. This is a figure from Accenture. They estimated the potential cost savings in AI applications to be, as when we get to 2026, to be 150 billion. So one of the things that I wanted to point out is that that is a lot of money. However, it's not money that we're going to try and generate and put into the system. It's actually money that we're trying to take out of the system. Everyone probably is well aware that our healthcare costs in the US are significantly higher than in other industrialized nations, given what we get for it. We spend the most per capita in the country, and we often have the worst outcomes in the entire world. And so we're really looking to improve our outcomes and decrease costs. So, this might seem like an exciting number until you really realize that we're trying to take it out of the system instead of generate new knowledge. One of the things that I thought was really interesting is the last bar on the bottom. The biggest opportunity is robot-assisted surgery, and there's a robot called Smart Tissue Autonomous Robot, or STARS, the acronym, and it demonstrated that it was more precise than expert surgeons and damaged less of the surrounding tissue. And so AI is also anticipated in this space to help provide new techniques, resulting in fewer complications and shorter hospital stays. So decreasing infections, like, for example, allowing patients to get up and to start moving that much quicker after surgery, which helps with recovery, speeds up recovery. And so I'm guessing that Accenture really extrapolated this out against kind of the aging population of the US, and that we're living longer, and that a lot of us, as we get older, are going to need hips and knee replacements. So some of the drawbacks of AI in healthcare. I categorized a few of them here. So in addition to the other ethical and social factors that are of great concern in healthcare right now, really is the question around accountability and liability. Today, providers carry malpractice insurance to cover unintended harm or wrongful death of a patient that come from decisions that they've personally made. So one of the questions and what the industry is struggling with right now is where does the accountability line, where does that lie if AI is the one making the predictions and the recommendations to the provider? Where is the accountability if the recommendation is coming from a black box and is not explainable, and so the physician does not even understand why they may be making that, or why they may be taking that specific action? Is the provider required to follow a recommendation provided by an algorithm that they weren't involved in designing, or they don't know the data that the algorithm was trained on? Where does the accountability lie if health insurance plans begin requiring providers to use and follow specific AI recommendations in order to be reimbursed or to participate in a network? So currently, our technical capabilities are much further along than our societal kind of understanding and wrestling with these difficult issues that are really more ethically and socially focused. And we all know that our current regulatory system and Washington, that currently the way that our regulatory system works it's really not able to keep up with the pace of the changing technology. And so while we're all very, very excited about AI in healthcare, we've got a couple of really, really difficult questions and answers to figure out before we're going to really see widespread adoption and the capabilities that we know are there. One of the other significant barriers that I want to call out and pinpoint is the availability of high quality data. Right now, that is a significant barrier in healthcare. And I'm going to share a quote here from an article that I came across recently. But basically, our data quality, where we have major gaps, is in semantic data quality. And so we don't have high quality data when it comes to meaning and being able to exchange meaning amongst different organizations or even different practitioners. And one of the reasons for that is because in healthcare, we aren't very specific and we aren't very consistent about using the same word to describe the same thing. And we also we don't have the same definitions for the same words. So, for example, many of you may be familiar with in healthcare, when you go visit your provider, a lot of people call it a visit. Just said that. And so to the layperson, they will speak about visiting a healthcare provider. As I have a visit with my doctor, I have a visit with my nurse practitioner, I have a visit with my ophthalmologist, etc. But in healthcare, we call those encounters. And so that's just a really hopefully accessible example of how we don't use the same words. We're not consistent. And if you imagine just that one example that I gave with visit and encounter, if you imagine that multiplied by the number of concepts and words that we have in healthcare across medicine, across care delivery, across care coordination, across insurance, it's really one of our biggest challenges to interoperability. One of the other things about our data is that AI fills the computational gap in the human ability, but it lacks the ability to reason or apply judgment, which is a big issue because of this semantic data quality issue that we have, that we don't use the same words. Also, these algorithms process data without intrinsic understanding or contextual awareness, and it's relying really on patterns and correlations in the data. But it can tell you that something is similar, but it can't tell you how that's similar or why that is similar. So it can't infer causation, which in medicine, that's really what we focus on. What caused what? If I do this, what is that going to cause to happen in my patient? What risk factors cause certain diseases? So causation is really our main tool in healthcare that we use to help treat patients. So I came across this quote from an article that I mentioned called Proceedings of Machine Learning Research this year. The article is called Do We Still Need Clinical Language Models? And the quote says, we show that relatively small specialized clinical models substantially outperform all in-context learning approaches, even when fine-tuned on limited annotated data. Further, we find that pre-training on clinical tokens allows for smaller, more parameter efficient models that either match or outperform much larger language models trained on general text. So that has big implications in healthcare for the use of these large language models. The large language models, they're going to cull information from all over the internet. A lot of that information that's on the internet is not accurate. And so what happens is that if we train a model on information that's a mixture of accurate and inaccurate information, we're going to get hallucinations. And that's what we see. And with these kind of continuously training large language models, they're going to be also generating additional information that other large language models will be learning from. And those contain hallucinations as well. So we're generating content that we know is producing hallucinations. And we also know that that same content is then being fed back into other large language models. And so in healthcare, we can't allow that level of risk. And so in healthcare, we are really focused on these smaller, more specific to a domain data sets in healthcare for AI. One of the emerging ideas that is gaining a lot of attention in healthcare right now to help address some of these issues that I just mentioned are knowledge graphs. And knowledge graph is really a representation of concepts, and it shows how they're linked to each other. And these graphs are easy for both humans as well as machines to interpret. And so this is really a powerful new tool that significantly revolutionizes the way information is organized and utilized. It is different than relational databases, which is what we have relied on to this point and what most of our expertise is in. But their ability to represent data and drive inferences, it's proving to be a game changer for information representation and retrieval in healthcare. And knowledge graphs are comprehensive for a domain, and they are constructed by domain subject matter experts. So people who really understand and can make judgment calls when we have situations where we're using different words that mean the same thing, or when we're using the same word that means different things. We have both sides of that coin in healthcare. And so knowledge graphs, I'm anticipating, are really going to be able to ground a lot of the AI that right now in healthcare we're very risk averse to using. We're not sure exactly how it works, but these knowledge graphs, I think, are going to be an important grounding capability. They also will help to address some of that explainability that we're not really able to do today with these black box algorithms in healthcare. If you look at this knowledge graph right here, and you kind of, go around the different circles and traverse the different relationships, it makes sense. And certainly to a clinician, this makes sense. And so knowledge graphs are really going to provide us with just much, much greater capabilities and much more trust in using AI. So some of the common challenges that we have in AI have been bucketed into 4 groups by a recent article that I read, and these groups really resonated with me. And so basically the big takeaway was that 82% of enterprises fail to scale AI and achieve meaningful business outcomes. And right now, as always, new technology is expensive. It's expensive until we reach a scale and we get more people in the market who are producing these types of products to bring the cost down. And so it's really a big expenditure and a big capital investment for an organization to say, okay, yes, let's move forward with using AI, given that they know that they may not see an ROI on it. And not a lot of organizations in healthcare that provide care, they don't have super healthy margins. They're not making huge profit margins to try out some of these new tools without a plan. I mentioned earlier that 44% of enterprises are challenged by data management. In healthcare, we have very few organizations that have mature data governance processes. And acquiring data is very difficult because we're not able to exchange information easily because of the semantic issue that we just talked about. And there are a lot of concerns about the bias in our data. Another challenge in healthcare is that how half of enterprises, they're dealing with this shortage of skilled AI talent. Everybody wants to engage in AI. People are interested in learning more about it. And there's not a lot of skilled resources out there to do this. And so the competition to, obtain these types of specialized expertise, it's very high. 33%, I already mentioned this, but a third of organizations cite finance and just the cost as being a barrier. And 42% of enterprises struggle to align their AI strategies to the business context. This last one is no surprise for me, having worked in healthcare and specifically healthcare IT for over 2 decades right now. If you're not familiar with the healthcare space and our use of technology, we have consistently been challenged to adequately and effectively adopt technology to improve outcomes for patients and to decrease costs and to increase efficiency. You may not be aware, or you may be aware that right now we have a very concerning trend in that a lot of our clinicians, physicians, nurses across the board, other types of clinicians, are really burnt out, not just from the stress of caring for sicker and sicker patients, but because they are forced to use technology that doesn't really help them do their job. Electronic medical records originally were created and developed as billing tools over 4 decades ago, and they really have not progressed much beyond that. The functionality does not really help clinicians bring up relevant information that they need to know, in order to make efficient use of the 15 or 10 minutes that they get to spend with you. That's just one example. And a lot of the tools that they use, they don't fit their workflows. The tools that they use, they may automate part of their workflow, but if it doesn't automate a complete workflow, it's almost harder for a provider to use a tool when it only supports half of what they need to do to accomplish a task. So what is happening today? The way I like to think about it, and this is a, gross oversimplification, but it's kind of easier for me to think about what people are doing in 2 camps. And so I call, those camps, one are the AI enthusiasts, and the other camp are those organizations who are really taking a sober consideration and approach to these tools. So I'm not sure how much people on the call have kind of experimented. I've experimented with a lot of different AI tools that are out there, ChatGPT being one of them. I've learned a lot about their capabilities. I've also learned a lot about their limitations. And I thought that I would share this photograph because I used AI. This was probably almost a year ago. But I used AI. I was due to update my professional headshot. And a colleague of mine had said, oh, I came across this great tool. It uses AI. You just have to give it pictures of you that you have on your cell phone, and it will create professional headshots for you. And said, well, I'll give it a try, right? It's low risk. I'm just experimenting anyway. This will be kind of a good learning opportunity. And while you may not be able to tell online here through this webinar that I do not have green eyes, I can certainly assure you that I do not have 3 arms. So I think that, this is a really good just representation of kind of where we are. We have incredible capabilities, a lot that we don't even know about right now, but we also, there are some serious defects, and some serious challenges. We're just starting on this journey. And so we have a lot to learn. I did pull together some patterns that I'm seeing across organizations who are successfully adopting technology. And I've gone ahead and I've bucketed them into 5 different categories. The first one being that organizations who are approaching AI from a socio-technical systems theory and design approach are really doing well. Oh, sorry about that. I skipped forward. And so what the socio-technical system design approach is that it's a combination of people, process, data, technology, and the environment. And each of those get equal weight. It's an approach that looks at the entire system that the AI tool is trying to be introduced into. And the goal is to optimize the whole versus any one part of the system. The next pattern that I'm seeing is that organizations who really focus on the business problem and have a well-defined use case are very successful. They have a deep understanding and knowledge of their stakeholders, the business and clinical requirements of those stakeholders, and the operational environment that their AI is going to be introduced into. Another pattern is that a lot of these organizations, they're pulling together multidisciplinary teams. They realize that it's not just about the technology and that it's about the people, the processes, the data. And so they're pulling together these multidisciplinary teams that at a minimum have a triad. So a team of 3 that includes a clinical and a business subject matter expert, someone who is an expert in AI technology specifically, and then someone who has broad IT expertise. The next pattern that I'm seeing is that these organizations, they have very mature data capabilities. They have sophisticated data governance, they have data pipelines, and they know what data they have, they know what data they don't have, and they know where they have quality data, and they know where they don't have quality data. So they have a very, very, very sophisticated and mature understanding of their data and how to work with their data. And so the last pattern is that I'm really seeing that the use cases, the availability of the expertise in the market, and that an understanding of data is really what is driving tool selection, which is a complete 180 from how we, usually approach technology in healthcare. We start with the tool and the software in healthcare. And so I'm really seeing this major paradigm shift amongst those who are successful. So we're going to go ahead and talk about a few examples now. I'm going to share with you, I think I've got 3 use cases here that really are illustrative of those patterns of successful organizations that I'm seeing in the market. And so the first one that I'm going to start with is the use of ambient scribe technology to decrease the burden of clinical documentation during an encounter and after an encounter. So at night, some of you may have heard of the term pajama time, and you may or may not be aware of the fact that many providers and clinicians, after they go home and they go to their kids' soccer game and they have dinner, they're spending additional 2-3 hours in the evening before they go to bed completing their documentation from patients that they saw during the day. And so we're going to talk about the Permanente Medical Group, which this one specifically is the Permanente Medical Group who exclusively contracts with Permanente, the health plan, and their hospitals. And so the Permanente Medical Group is the physician group for Kaiser Permanente. And they approached and wanted to learn what this ambient scribe technology was capable of doing. So this technology uses a machine learning applied to conversations to facilitate scribe-like capabilities in real time. And they have great potential to reduce this documentation burden. In addition to that, the physician, instead of looking at the computer, they can be talking with their patient face to face. And so they're really hoping that it's going to enhance physician-patient encounters and augment clinician capabilities. And so in October of last year, TPMG, they enabled ambient AI for 10,000 physicians and staff to augment their clinical capabilities across diverse settings and specialties. And after 10 weeks, the tool had already been used by roughly 3,500 physicians to assist in as many as over 300,000 patient encounters across these different medical specialties and locations. So, some of the patterns that we talked about earlier that I saw when I read this article and studied this article that Permanente Group had published in the New England Journal of Medicine Catalyst, that's their innovation journal, was that they truly took that socio-technical design approach. They approached it with a strategic perspective. They had user-centered design. They also, in that user-centered design, they chose to use smartphones to transcribe the encounters. And those smartphones didn't retain audio recordings, so they were thinking about privacy and security of their patients' information. The user-centered design, to get back to that, they chose to pilot this technology across many diverse types of providers. So all the way from pediatricians to general practitioners to psychiatrists, so that they could ensure that when they were ready to move beyond the pilot, that this tool was generalizable across all of their different physicians and the different specialties that they have in their organization. They focused on the business and well-defined use cases. They had an appropriate scope picked out. They decided early on that while eventually their end goal is to integrate these auto-scribed documentation notes into their electronic medical record, they did not start there. They wanted to understand the AI technology and the scribe technology aside from integrating into their EMR, and so they started with an appropriate scope. They also developed a robust evaluation framework that they were going to use to evaluate the effectiveness and the safety of this technology. They had multidisciplinary teams. So they had a team of over 20 people, physicians, administrators, statisticians. They even had patients included. They had clinical informaticists, and they had the lead of their electronic medical record system, which is Epic, all involved and worked together as a team. One of the other things to mention about Kaiser Permanente that may not be well known is that they have very mature and sophisticated data capabilities. They have developed over decades something called convergent medical terminology, which is really sort of like a knowledge graph. They have standardized the use of specific words and specific definitions across their entire organization, which spans more than 5 states. And all of their clinical applications. So that was so successful for their organization that they gave it to the National Institutes of Health so that the rest of the other healthcare organizations in the country could benefit from that. Kaiser has decades of experience implementing technology. One of the other things is that they are kind of your original value-based care organization. They are a capitated reimbursement model. And so, they know that they can't afford to implement technology that they are not going to see a return on their investment.
Michelle,
Yeah.
we are drawing near the end of the presentation. I think we may have to wrap it up, but I think given that this is such a comprehensive presentation covering these 3 different studies, perhaps what we can do is we can create a workshop around healthcare exclusively and go more in depth into this subject matter.
Sure. Yeah. Thank you. I apologize. I thought I had 10 more minutes, but thank you for letting me know. And I'd be happy to participate in an all day workshop to get into this more. The references are on the slides. And so feel free, and I encourage you to pull up these different studies themselves. And hopefully the slides are self-explanatory and you can follow along with them on your own. Thank you, Joaquin.
Michelle, I'd just like to say that I really appreciate you going deeper into these research papers that showcase the actual work that has been done to methodically implement these things in practice. Um, it's not it's not common that we get this in-depth insight and breakdown of these sort of research papers. So I appreciate the angle that you're taking. And again, it's my fault. Maybe next time when we have the full day workshop, we can certainly bring in more, even different practitioners to weigh in with their perspective as well.
Yeah, that would be great. I look forward to that. Thank you so much.
Thank you, Michelle.